Good afternoon and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, Marketing Specialist, and I'll be your moderator. We are excited to welcome Dr. Ann Brady as our speaker today, as she will discuss the Ivory ReLeaf hands-free HVE system and how it can help clinicians like yourself enhance safety, productivity, and patient care. Dr. Brady is the owner of Desert Sun Smiles Dental Center in Glendale, Arizona, as well as the Director of Education for the Pankey Institute. Before we get started, we've got a couple reminders for you. At any point during today's webinar, if you have a question, please type it into the Q&A section of your control panel, and we will get back to you via email within 2 business days. And Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Dr. Brady, thanks for joining us. Take it away.
Well, thank you, Adam. It's really an honor to be here to be able to share this information. And also thanks to Henry Schein for putting this on and providing this much needed information. Always fun for me to talk about something that I'm using all the time in my practice and that has really changed how we practice dentistry. So we're going to spend our time talking about a very specific isolation device, isolation solution that came on the market just a couple of years ago from Ivory, which is a brand that's part of the Kulzer family, and it's called ReLeaf. I've actually been fortunate enough that I've been able to use this in my office for quite some time because I was one of the first offices that kind of got to test drive it and fall in love with it. So let's just step back for a second before we actually talk about relief and talk about isolation in general and why we isolate. One of the, obviously the first ones when I say that, why would you isolate? Usually the first place that we go, especially if you're a dentist listening, versus an auxiliary or hygienist, is your brain goes to, well, we do adhesive dentistry today and we need to have moisture control. Absolutely no question. Most of our dental materials that are on the market today do better. We get better clinical results. The materials set better, they last longer when they're managed in a dry, well-isolated oral environment. And then if you say they're resin-based materials, then that actually sort of increases the importance of having a super well-isolated, dry, controlled environment so that we get the maximum success we can get out of those materials. When I ask dentists about adhesive dentistry, whether it's about direct composites or it's about bonding in some of the new indirect ceramics that we do, and we start to talk about what they would like to see, pretty much always, maybe not the first thing that comes up, but the second to fourth thing that comes up is, I'd really love to see those restorations last longer. It's so frustrating when you see the patient back at a hygiene visit and there's stain at the marginal interface. You can't tell, is it just stain? Is it leaking? Is it secondary caries? And it prompts us to replace those restorations. And so many of those things that we see with adhesively placed restorations actually are going to be less frequent and they're going to take longer to show up if we're managing the environment because those materials are not highly water tolerant. So absolutely no question, we're going to get improved clinical outcomes from our materials, our procedures, greater longevity of the dentistry we do for our patients in a well-isolated field. Okay. Then I'm going to add a couple more to that. One of the first ones I'm going to add, which isn't often the one that comes top of mind, is patient comfort. I watch day in and day out in my clinical practice here in Glendale, Arizona, as patients struggle to, and if you could see me, I'd make the hand gesture for in quotes, be a good patient. So they're trying really hard to be a good patient. They're trying to stay open. They're trying to keep their tongue out of our way, even though they're not exactly sure where their tongue is out of our way. And at the exact same time, they're trying to manage that unbelievable need to swallow. We're putting water in their mouth. It triggers that reflex. And for some patients, especially if they're dependent upon mouth breathing, it makes it even worse until finally they can't help themselves anymore and they swallow. And if you can see their eyes, there's always sort of a guilty look on their face like, uh-oh, I hope I didn't just screw that up. And so anything that we can do to manage the oral environment, to keep their saliva from building up, to keep the water we're putting in there from building up, to keep the materials that we use that have really, sour taste or taste bad, and then that makes them salivate. Anything we can do to manage that really, really improves the patient experience. And the more comfortable the patient is, the better the procedure will go. We'll get better outcomes. It'll be more efficient. But it also, for me, really is an incredible piece of marketing my practice. Is to be thinking about what can I do to make dentistry. And you might not agree with the word pleasant, but as pleasant as possible for my patients to make this experience as easy as possible. So just like we want to give really comfortable injections, the better a job we can do managing the oral environment and all of the things we put in their mouth, the better that appointment goes. That patient comes away saying, gosh, that was one of the best dental appointments I've ever had. And they're much more likely then to talk about our offices in a positive way and refer friends and family. So patient comfort, kind of, that's why it's right at the top of the list. Okay? Visualization, you know, visualization and clinical outcomes go together. Visualization and efficiency go together. The better I can see or the hygienist can see, the better a job we're going to do. And having to stop all the time, either to wipe my mirror off because there's moisture that's spraying and building up on my mirror, or my assistant is trying to dry the mirror with an air water syringe and it partly blows air and it partly blows water. So I'm not sure if it's helping or it's not helping. Um, you know, that ability to be able to see what I'm doing is dramatically improved when we have really great high volume isolation. And then that, of course, goes to efficiency, whether I'm stopping because I need to get a 2x2 and wipe my mirror, or we're stopping because I have to get out of the patient's mouth so they can close and swallow and catch their breath. Every single time you do that, it may only be 10 seconds, 20 seconds, but it adds up, right? And it becomes inefficient. And so isolation always makes dentistry a little bit more efficient. And then the last one on my list, and not last because it's least important, but last because it's probably the topic of the day, is thinking about isolation today from a standpoint of safety. Now, this is not a new conversation. We've been doing studies in dentistry to look at controlling aerosol, controlling what we call spatter or splatter for 30 years or more. From a standpoint of improving the safety of the oral environment. But obviously, everyone is well aware of the fact that a conversation that we were paying attention to became front and center and really has been the epicenter of what we've been thinking about for almost the last year. So let's spend a little bit of time and just look at that piece of the puzzle. Now, I know you can't read all of the numbers and everything on this slide. I didn't put it there. I just put it up there as a way to show you some of the science and some of the references. We do have studies that look at spatter reduction and aerosol reduction using a variety of different operative field techniques that go all the way back into the 1980s. And then obviously there's been a resurgence of popularity of that science in the very recent months because of COVID-19 and the things that are happening in the world today. And what we knew all those years ago, and what we've basically reproven with some really good new research, is that high volume evacuation is the key. And so when we compare high volume evacuation to the saliva ejector or a low volume solution, there's no comparison. And as soon as we go to high volume evacuation, then we see dramatic reductions in both spatter and in aerosol at the level of the operator, at the level of the patient, and at the level of the environment in the ambient room. Now, there are some specific parameters that go to the surface area of the tip of the high volume evacuator, and then distance from the tip of the high volume evacuator to the source of the water. But in general terms, high volume is the key. And this is part of a recent study that has just been coming out. And I want to just kind of show you a little bit of a close up on some of this data. So, this is a graphic from some of that study. And this is specifically looking at aerosol. And so I don't really even have to explain this to you other than to tell you that the bar all the way on the left-hand side of the screen is the control. And then every one of the other methodologies that were tested in the study use high volume evacuation, and a high volume evacuation that actually meets the criteria. So it meets the standards for the minimum surface area, and it meets the standards for proximity from a standpoint of proximity, the tip of the high volume device to the source of the moisture. So the tip of the cavitron, the tip of the high speed handpiece. And they were specifically measuring aerosol particles that were lower than 2.5 microns, which are the ones that we should be concerned about because our masks can screen stuff that's larger than that. So really quick general overview, you look at this graph and what you can see is that high volume evacuation in its many varieties is the answer to controlling aerosol, and it actually reduces the aerosol over 95%. In all of the studies that have been done, upwards to even 98 or 99% in some of the studies with some of the devices. So that's really good news from a standpoint of safety. And it should make us all feel really good that we've had the tools and the devices to be safe and to protect ourselves and our team members and our patients all along. And this experience has given us the opportunity to just go back and verify that and that it was doing what it needed to do. Now, they did the same thing and they said, well, let's actually look at sort of the max aerosol you can create, which is high speed handpiece, 200,000 RPMs, doing a crown prep, water's hitting the tooth and spraying back out to see if you're going to get the same results. And so basically, same thing. You can just look and you can go, okay, that bar graph on the left-hand side, and you can see it's now 4 to 5 times higher than it was in the previous procedure, because this is the most aerosol we get during a crown prep with a high-speed handpiece. But again, all of the different high volume evacuation systems did a really, really phenomenal job at controlling that aerosol. And in this case, one of the things that they did find is the greater the surface area of the high volume device, the better a job it did, and the closer the proximity of the high volume evacuation device, the better a job it did. So we can kind of look at that in both ways and say high volume, positioned properly, proper surface area. That's what we need to be doing. That's our primary line of defense. Now, the other thing that they looked at is what we call spatter. I've heard some people say splatter. Those are the larger droplets that are actually leaving the oral environment. From a standpoint of breathing these in, much, much less risk because the weight of the droplet, it actually hits the ground. It doesn't stay in the air. So it's not something that you can inhale. But if you've got water droplets that are contaminated with particles, virus, bacteria, and they're actually spattering and they're not getting on your face, on your clothing, then you're touching with your hands if you're not doing good hand washing or hand sanitizer, then you can contaminate. So let's see how we do with spatter. And they actually kind of create a prototype where it's in the position of the operator. They put a face shield on, except the face shield is divided up so that they can actually measure the droplets that hit. And again, we can do the exact same thing and we can say, okay, control is all the way on the left hand side. And then everything else are different versions of high volume evacuation. And again, now we can see in the realm of spatter, which was really interesting, is in their study, this is a much, much smaller problem than aerosol is, just from a standpoint of pure quantity of what's happening. But again, anything that's using a high volume evacuation system is actually reducing it significantly. Just a regular high volume device reduces it literally by 75%. So it drops down to a quarter of what it was. There are other devices that they tested that reduce it, more in the range of 50%. I found it really interesting that the one that's rubber dam actually didn't reduce it quite as much. And I happen to know a couple of the people on this study, and they said, unfortunately, because the moisture hits the rubber dam and can then sort of bounce. So it sort of increases this. But high volume evacuation, yet again, is the key, obviously, in addition to the PPE that we've always done, and then the new level of PPE that we've done. So, no question, anything that's a high volume evacuation device is what we should be doing as an absolute standard in our practices, in addition to our personal protective equipment. So, with that as background information, let's dive into ReLeaf. So, what is Ivory ReLeaf? It is a hands free intraoral high volume evacuation device. And it actually meets all of the parameters that we just discussed. So the device itself connects to the high volume tubing evacuation system that is already in every one of your operatories. It is got an increased surface area over just the tip of the high volume. Because the leaf design, that surface area of the leaf has holes in it and is suctioning. So you've actually got a dramatically increased surface area, which makes the device even more effective. And we can put it exactly where we need it. So it's very, very close in proximity to the handpiece or to the tip of the ultrasonic. And they're incredibly comfortable for the patient. So let's talk for a second about hands-free, because when we think about hands-free, you might go, well, that's not a big deal. I'm not in dental school anymore. I don't hold my own high-volume evacuation device. But you do have an assistant that's holding that high-volume evacuation device. And if they've got one hand that's completely consumed by holding the high volume, then they're going to be less effective at handing you instruments, passing you materials. And then add to it that if they are also having to turn away to look at something else, to get you something from the tray table, how well are they keeping the tip of the high volume evacuation device directly in the proximity of where you're actually generating that water spray, so that they're controlling the aerosol and the spatter. But then I also take it to the next conversation, which is hygiene. One of the places in my office that we use the ReLeaf, and we use it on every single patient that comes in the practice every single day, is in our hygiene operatories. So both of my hygienists use it, and they use it religiously. Pretty much can't sit in their chair without having an Ivory ReLeaf used, because it is such a phenomenal device when we think about cavitroning or ultrasonic scaling. And so, where this device sits is it sits in the buccal space. So I always tell everybody, imagine that the little green leaf, which is the disposable part, is just a really comfortable rubbery plastic triangle. So exactly where you would put a triangle is where you're going to put the little green leaf on the ReLeaf, right in that buccal space. And then you can see the little U connector that's a brighter white plastic material. That is actually sort of the brainchild. It's the exquisite piece of the design of a ReLeaf. Because what it does is it literally hooks right over the inside and the outside of the commissure on the side of the mouth. It holds the leaf in the buccal space, And then the weight of the tubing connected to it and the high volume, because of gravity, it start to kind of pull it toward the back of the mouth and hold it in place. So it's going to stay exactly in place. So I don't know how many times you've done this in your career, but for me, it's absolutely countless that I've tried to figure out today. I'm going to know the exact magic recipe for bending a saliva ejector so that it hooks over the side of the mouth and the tip of the saliva ejector stays exactly where I want it at the back of the mouth to suction up all of the saliva and the water. There's two problems with that. Number one, it's a low volume evacuation device, so it doesn't meet our criteria today for aerosol safety. But the other challenge with that is in almost 33 years of clinical practice, I still have never figured out how to bend a saliva ejector so that it actually stays in place. So it stays for 30 seconds, 60 seconds, 90 seconds, and then it starts to move. And when it starts to move, my mirror's getting wet, the patient is drowning, and then I take it out and reposition it. And we do that over and over again in a very inefficient way, each time thinking, I'm going to figure out how to bend it. Okay. You will not have any of those problems with ReLeaf. It's just absolutely magic the way it stays in place. And what you do is if you're working on the right hand side of the mouth, you're going to put it in the right hand buccal space. And you're going to ask the patient to just gently turn their head to the right so that gravity is pulling all of the fluid toward the ReLeaf. And if you're working on the left hand side, you're going to actually move it and put it in the left buccal space, have the patient turn their head to the left. Those work also just for visualization purposes. So when my hygienists are cavitroning, they do half the mouth and then they move the ReLeaf and then they do the other half of the mouth. It's incredibly comfortable. It suctions incredibly well so the patient doesn't feel like they need to swallow. And if the patient wants to, you can just take your hands out of their mouth and they can actually just close their lips right over the ReLeaf. You do not have to take it out and they can just close. It'll completely evacuate the oral environment. They can swallow and it can totally stay in place because it's that comfortable. Okay? The other phenomenal piece about this is the one piece is disposable. So you buy the little green leaves and then you throw them away. And then the tubing is autoclavable. So the little white U-shaped connector, which is the magic for holding it in place, is autoclavable. And then that first section, it's about 8 to 10 inches of tubing, is autoclavable. So you're going to want enough of those that you can actually cycle through kind of a day in your office. And you're not going to have to rush them through the autoclave or the statum. So this is kind of a close-up photograph of this so we can see that. So these little green leaves are the disposable part. And they are really kind of a very soft material. And that entire side surface area is actually suctioning and pulling air pretty intensely, pulling water, liquid pretty intensely. This white U shape piece is going to go in the autoclave. And then this first 8 to 10-inch tube is going to go in the autoclave. And Ivory sells these sort of in starter kits so that you can get all the parts and pieces. And then you can buy everything sort of onesie, twosie. So like the actual leaves, that's what you're going to need to turn over the most. You can just buy those, in a bag of just getting the leaves. Figuring out how many of the autoclavable pieces you need. I would tell you in our office, we did our best guess at the front end and said, how many do we think we need? Okay, 2 hygienists, this many patients a day, plus using them for restorative procedures. And then I will tell you, we actually ordered more because we're not quite as good at running things through the autoclave during the flow of a busy day as we thought we were. So having some extras and never running without them was really important. So we ended up sort of increasing our inventory or our stock of those pieces. It's really interesting for me from a hygiene perspective. When I first presented this in my hygiene department, which was pre-COVID, because I had these in my office before then, they were a little bit like, okay, if you say so, because change is a tough thing. It's a tough thing for all of us. And so, I kind of made them a deal and said, let's do this. Let's, use them when you do the next time you do a hygiene visit on one of our team members, one of my family members, somebody where you can say, hey, this is a new device. I want you to give me some feedback and, tell me what you think. And I actually think one of my daughters was one of the first hygiene patients we used it on. And when we got done, the hygienists were amazed because she was like, oh my God, that thing was awesome. It made my appointment so much easier. Is that something y'all are going to use all the time? I mean, even from a standpoint of like with prophy paste, we leave them in while we're polishing, and then you can rinse the prophy paste and you're not having to reach for the saliva ejector or reach for the high volume. The hygienists don't have one hold hand. I've seen some of the other new high volume evacuation devices that have come on the market. And the challenge is now the hygienist has both hands engaged. So they've got the Cavitron in one hand and the high volume in the other hand, or you've got an external device. These are just so much better from a hygiene perspective. I use them all the time from a restorative perspective because they're not on the lingual, because they don't put any pressure on the tongue. They don't trigger patients' gag reflex. And so that's really important for a lot of patients. The other piece of that is anyone who's got TMD, has problems with their joints or their muscles. The ReLeaf doesn't crank them open and lock them open on a bite block, potentially hyperextending the joint or straining the elevator muscles. And they can open and close, they can move, keep that synovial fluid going around in that temporomandibular joint, have a chance to make sure the muscles aren't cramping or contracting. So it's really phenomenal for that perspective. And again, I put it on the side I'm working on. So if I'm working on teeth on the upper or lower left, the ReLeaf is going to go in the left buccal space. And if I'm working on the right, it's going to go in the right buccal space. I can't really think of a procedure that these aren't great for. Like I think about even simple cementation. It's so easy to put these in. It's so quick to put these in that, like literally in 30 seconds, we can go ahead. My assistant will have this in before she takes off the temporary. Now she can take the temporary off. She can clean the temporary cement and rinse herself without having to reach over and use her other hand to evacuate. And then I've already got isolation in place as I go to try in the restoration, seep the restoration, manage that oral environment. So really, I put any time at the last bullet point because I honestly can't think of a procedure that I do where it wouldn't be appropriate to use the ReLeaf because they're just that quick, easy, convenient, and helpful. So how do we use these? It almost is kind of funny. I'm going to show you a quick little video on how to do it, but it's almost so simplistic that you don't need the video. So what do you need? Kind of what's your armamentarium, as we would have said in dental school. So you've got to have all the tubing. So when you buy the starter kit, you're going to get all of the tubing and you're going to get a starter pack of the leaves, and the kind of greenish leaves are the adult size, or what we might call the regular size. So you're going to need a new leaf for every person, and you're going to autoclave the little white U and that first piece of tubing right down to the sort of clear connector. So you're going to want enough of those so you can bag them and autoclave them. They did just recently come out with what they refer to as the ReLeaf minis. And you can see that they come in pretty cool colors. So pink and baby blue and this lighter greenish yellow. Where do we use those? Pediatric patients. So if you see peds patients in your practice, you're going to want the minis. And we have just a couple of patients, adult patients in our practice who have really limited opening, and we will use the mini. Although I will tell you, if the patient can open, if their range of motion, their opening is even 30 millimeters, you can get the regular adult size in. And I would suggest you use the largest one that you can use because larger surface area, better control of aerosols, and they're so comfortable that it's really not going to be a problem. And so what you're going to do is you're going to just put a brand new leaf onto the U, which is connected to that first end 8 to 10 inches. And you're just going to insert it in the buccal space. And then you're going to get to work. I mean, that is literally how simple it is. Again, if you're doing procedures on both sides of the arch, put it on one side, do what you need to do on that side of the arch, complete it, and then move it to the other side. You don't need a new leaf. You can just take it out and move it. And remember, the patient can close on it. So, partway through the procedure, if you're stopping, you're doing something, you don't have to take it out. Just leave it in, and the patient can just close right over it. When you're all done with the procedure, you're going to throw away the little green leaf. It's the disposable part. You're going to just rinse, ultrasonic, and then bag the little white U and that first piece of tubing down to the clear plastic connector. Throw it in the autoclave. And then we wipe everything else out. We run the high volume evacuation cleaning solution through the tubing, and you're ready to go for the next patient. I would really highly encourage, if you've not tried ReLeaf, you absolutely want to try it. You want to get this in your office. And the only caveat I'm going to tell you is make sure you have enough of them once people start to try them, because your hygienists are going to want them. If you have assistants doing sealants, they're absolutely going to want them. So you're going to need to make sure that you have enough of these to go around. So with that, I am going to say thank you once again to Schein and to Kulzer for giving me this opportunity. I really hope this information was useful and helps you be more efficient and more effective back in your dental practice. And with that, I am going to turn everybody back over to you, Adam.
Thank you, Dr. Brady, for your time and information on the Ivory ReLeaf. If anyone has additional questions about the ReLeaf, please email us at webinars@henryschein.com. Additionally, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. As a thank you for attending, everyone will receive the recording of this webinar via email sometime in the next week. Thank you all for joining us, and we look forward to seeing you on future webinars.